Welcome everyone, and thank you for joining the National Foundation of Swallowing Disorder webinar series. My name is Ed Stever. I'm the president of the NFOSP. I'm also a head and neck cancer survivor with most of my treatment in the 2005 to 2007 timeframe, and I was diagnosed with severe dysphagia in 2007. If we could go to the next slide, please. This slide represents the countries that people registered from to attend today's webinar. Everything highlighted in blue. And there's nothing like a pandemic and a common enemy to bring a lot of people together to share information. There's at least 35 countries represented on today's call. And it's not just the diversity of the geography, but it's also the diversity of who is on the call today. So I thought I would go through and just let you know who has the categories of people that have joined us today. So we have people with dysphagia, a head and neck cancer patient from 22 years ago, one 17 years ago, someone with severe reflux, and a person suffering dysphagia due to a stroke. Then we have SLPs in the ICU that are treating COVID patients. We have SLP researchers and educators, nutritionists, dietitians, occupational therapists. We have SLPs who specialize in pediatrics, stroke, neurologic disease, TBI, spinal cord injury. Those that work in inpatient acute care and neurorehabilitation. And then we have many physicians, ENTs, and even a number of psychiatrists that are seeing people as a result of the pandemic. We have therapists with mobile P services and who work in rehab hospitals. Those that are in skilled nursing and long-term care facilities. And then we have quite a lot of students that have joined us, as well as SLPs. I think the largest one that I saw have been treating patients for almost 4 decades. So we have a very, very wide group participants today. If we could go next slide, please. So the NFOSP mission is to improve all those, the lives of all those with a swallowing disorder. And to do that, we facilitate patient support, provide education, such as today's webinar. We've raised awareness. June is National Dysphagia Awareness Month, and we have a number of campaigns to help raise dysphagia awareness. And you may have seen that in some of the kickoff slides before I came on, but the ability to buy a t-shirt for $20. That is a great conversation starter. And we promote promising research. Although DRS was not held this year in person, we awarded a $2,500 grant to to someone who had submitted the best patient innovation research in the dysphagia community. I'd like to spend just a minute on support and how we do support. We refer people worldwide to swallowing specialists. Just in the last week, we referred someone to specialists in Italy. We have 15 in-person support groups in the US. We have 2 online Facebook forums, one for pediatrics and one for adults. And our pediatric forum gets over 1,000 posts a month with people helping people for their little ones. It's really great to see people coming together. And lastly, this Friday, we're kicking off our first real-time virtual support group. So it will be live. We still have room for 1 or 2 additional patients or caregivers to join us. And there'll be a link to that in the post-webinar email that's sent out. So if you have an interest, please let us know. A few housekeeping items. You will be muted during the presentation. To ask a question, click on the blue question mark and type in your question. Our Foundation Executive Director, Elizabeth Lifton, will be helping to field the questions, and our keynote speaker, Stevie Marvin, will have time during her presentation to answer your question. And one little twist on this, if you have an experience that you would like to share, that's great. Type that into the question box. And if we have time, we'll share your experience. Not your name, but just the experience that you've had. This webinar is being brought to you free of charge, thanks to the generosity of an unrestricted educational grant provided by Bracco Diagnostics. And if we can move to the next slide, please. I would like to introduce Stevie Marvin. She earned her board certification in swallowing and swallowing disorders. She works at the University of Wisconsin Hospital and has been focusing on swallowing disorders for the past 12 years. She has volunteered her time today. We're very fortunate to have her as our keynote speaker. And with that, I'm going to turn this over to Stevie to share her experience. So, Stevie, please take it away.
I'm coming, everyone. Just hang on. Okay, I think everyone can see me and hear me, I hope. One more thing, I just got to get this out of my way here. Do that. All right, so I'm thrilled to be presenting this morning on management of dysphagia in the ICU. As Ed said, I'm a speech pathologist and I work at the UW Health's Voice and Swallow Clinic in Madison, Wisconsin. I specialize exclusively in the evaluation and treatment of swallowing disorders and have done so for the last 12 years. 90% of my work week is spent seeing patients, both inpatients and outpatients, but I do have 10% of my work week dedicated to research time. But even though I do research, I am primarily a clinician. Here are my disclosures. They're all related to my employment at the UW Hospital. But I also want to make one other disclosure here, and that is that practice patterns in the ICU are rapidly changing because of COVID-19. I want to be clear that I'm not an expert on COVID-19, nor am I an expert on SLP telepractice. Every hospital is facing their own set of challenges based on surges in COVID, in patients with COVID, availability of PPE, staffing changes, and just our general lack of understanding on this particular disease. I'll tell you how we're managing our patients with COVID-19 at UW Hospital currently right now, but that may be different a month from now, it may be different 6 months from now, it may be different a year from now, and what we're doing may not work for your hospital. So throughout the talk, I'm going to include this little coronavirus symbol here on slides that either there is particular relevance for patients who have COVID, or there may be something different for patients with COVID. And then near the end of the talk, I'll have a special section, again, on how we're managing our patients with COVID. So this is a little roadmap about what I hope to cover today. The caveat here is that when Elizabeth asked me if I would do this talk, I said, sure, I can cover management of dysphagia in the ICU in 45 minutes. And then as I started putting this together, I realized that was almost impossible. So she's granted me an extra 10 minutes, but then I also am going to kind of narrow this focus here down and talk significantly more about recently extubated patients compared to tracheostomy or high flow nasal cannula, in part because I think that that's an area of interest for hopefully the audience, and also because that's a focus of my research. So ICU patients in the United States, they estimate that there's over 5 million ICU admissions annually, accounting for about 20% of hospital admissions. And 20 to 30% of those ICU admissions require mechanical ventilation. And certainly this number may be different in the light of the pandemic, but you can see it's a huge portion of admissions are in the ICU. But what makes ICU patients special? Why do they get their own topic of discussion today? Well, they're obviously a very heterogeneous group. You can have old patients, young patients, patients with admitted for respiratory issues, cardiac issues, neurologic issues, the list goes on. But they also have some commonalities, and that's where we'll focus today. So this is a list of some characteristics that may be found in ICU patients. Certainly not every ICU patient checks all of these boxes, but enough of them do that I think it's worth discussing. I'm really paranoid that people can't hear me or see me, but I am assuming I would get some sort of alert if that was the case, so I'm just going to keep going.
You're good.
Okay, thank God. Sorry, I've never given a presentation where there's absolutely nobody in the audience. It's really kind of throwing me off, but I'm gonna focus back up right here. So the first thing we'll talk about is frailty. And frailty is a multidimensional syndrome related to aging, certainly not unique to just the ICU. It involves a loss of reserve and accumulation of deficits in both energy, physical, cognitive, and health. It's estimated that approximately 30% of patients in the ICU are frail, and that frailty is associated with increased hospital mortality and long-term mortality, and those patients are less likely to discharge home. Frailty also involves a loss of functional reserve and impaired resistance to stressors, which I think is so relevant in the ICU because essentially being in the ICU in and of itself is a stressor. So what does this mean for our evaluation and treatment as speech pathologists? Well, if you have a patient that's frail, you may wonder, did they have some baseline dysphagia prior to admission? And could that loss of reserve maybe tip that subtle subclinical swallowing changes or subtle dysphagia symptoms that they were having at home over the edge to be a more worsening, clinically significant dysphagia requiring some intervention? And you also wonder, for a frail patient who has reduced resistance to stressors and maybe reduced bounce back, what it could mean for their prognosis for recovery and their timeline for recovery. ICU delirium is also super relevant for us when we're talking about swallowing. So delirium is an acute disturbance in consciousness or cognition that fluctuates over time. It's estimated to impact anywhere from 19 to 80% of patients in the ICU. That's a huge range, obviously, but it's been noted to be higher in mechanically ventilated patients and obviously can vary with patient population and age. And I have this little coronavirus symbol here because there is some chatter among ICU physicians about whether patients with COVID may be at increased risk for delirium, and even regular ICU patients in the era of COVID may be at risk for, or increased risk for ICU delirium. And that's because some of the delirium prevention methods, such as promoting normal sleep-wake cycles, reduced use of restraints, and reducing social isolation, are negatively impacted when family is not allowed at the bedside. And so our hospital, at least in the initial parts of this pandemic, was put a ban on essentially all visitors at the bedside, and they're slowly opening that back up. But there was some talk that by having ICU patients not be allowed to have family at the bedside, they may be at increased risk for delirium. In addition to that, if a hospital is undergoing a surge in COVID patients and is short-staffed, some of those other prevention methods, such as sedation weaning protocols, may not be executed in the same way. So what is the impact of delirium on swallowing? Well, we really don't know, but there was a study published by Dr. Leader that found that disoriented patients were more likely to aspirate. Now, they certainly weren't looking at delirium specifically in this study, but it does make you wonder. And delirium can definitely impact feeding behaviors. I've seen patients with hypoactive delirium who make no attempt to feed themselves or initiate eating. And then I've seen the hyperactive delirium cause patients to be almost unable to attend to the task of eating and swallowing. They're just too distracted. They're kind of all over the place. And it definitely impacts participation in the evaluation and treatment in terms of ability to follow through with strategies or participate in the evaluation. If you've ever tried to teach a delirious patient to tuck their chin, you kind of know what I'm talking about. And because delirium waxes and wanes, we have to consider it when we do our evaluation. So if you have a patient that has known fluctuating delirium and you see them when they're really at one of their best times, you have to think about what that may look like when they're more delirious later in the day at dinner time. So we have to factor that in our treatment recommendations. ICU patients can be at elevated risk for infection. This is a list of factors that have been shown to be independently associated with increased risk for hospital-acquired infection, and you can see that 3 of them are directly related to being in the ICU. So what does this mean for us as speech pathologists? Well, we may wonder, are our patients in the ICU more vulnerable for pneumonia? We don't know, but it's something to think about. Medical complexity. Now, certainly, again, not unique to the ICU, but very, very common in the ICU. So you could have a patient, a made-up patient, admitted for a motor vehicle accident, but it's not just that motor vehicle accident trauma. They have rib fractures with an impaired cough. They have a subdural hematoma impacting their cognition and their ability to participate in our evaluation and treatment. And they're in a cervical collar impacting, again, postural strategies, and in some cases, swallowing ability. But it's not just that motor vehicle accident. They also have Parkinson's, and when you talk to family, there was a subtle cognitive decline going on at home, and there was some weight loss prior to admission. So again, it's not just one of these things in isolation, it's all of these things swirled together. And I think there's no place that that's more evident than in these critically ill ICU patients. Polypharmacy could probably have its own 1-hour talk, so I'm not going to say a lot about it right here, except that I'll say that ICU patients tend to be on a lot of drugs, including sedatives, and we have to think about that when planning our evaluation, and particularly sometimes the timing of our evaluation, that those sedatives may take some time to leave their system. ICU acquired weakness. Now, this is a hot topic in the critical care field. It's been shown that patients with advanced age are at increased risk for ICU acquired weakness, which is not surprising given that advanced age pretty much increases your risk for everything. Also, patients with sepsis, longer ICU stay, increased duration of ventilation, and bed rest. And these impairments can last for months or years. One particular type of ICU acquired weakness is diaphragm weakness. This study found that approximately 80% of patients with prolonged mechanical ventilation had diaphragm weakness, and that diaphragm weakness was twice as common as limb weakness, and there was no relationship between diaphragm and limb weakness. So what does this mean for our evaluation and treatment? Diaphragm weakness can impact cough strength. And we know how important that is for protecting the airway, particularly if there is some penetration or aspiration. It also can impact feeding ability. And I know that we're not treating feeding ability per se, but I've seen patients that are cognitively intact and know they're supposed to take small bites, but take these big heaping spoonfuls because they don't have that precise control to take the smaller forkfuls or spoonfuls. And we may also wonder about weakness of swallowing musculature. And I'll circle back around to this and mention a study that may suggest that that might be the case when we get a little further into the talk. And another thing I guess I meant to mention on the previous slide is because that diaphragm weakness is not associated with limb weakness, you could show up at a patient's bedside to do their evaluation, and you're watching them transfer to the chair with the nurse. They look pretty strong, but that doesn't mean you can assume that they have good diaphragm strength or good cough strength. Oh, I meant to make SpongeBob leave a little sooner, but well. The final thing on that list of factors is compromised respiratory status. It's estimated, like I said before, that 20 to 30% of ICU patients require mechanical ventilation, either through non-invasive positive pressure ventilation like a BiPAP, or through ventilation through an endotracheal tube or through a tracheostomy. And even patients that don't require prolonged mechanical ventilation or any mechanical ventilation can have impairments in their breathing, and that coordination of breathing and swallowing can be impaired. And we know that that can increase risk for aspiration. Now, in a moment, I'm going to transition to talking about those different patient populations. But before I do that, I want to talk about my general approach to dysphagia care. And I just decided this would be a good time in the presentation to do that. Throughout my interactions with patients, I'm constantly thinking about both their risk for dysphagia and their vulnerability for the consequences of dysphagia. So starting at the chart review, through the bedside, potentially instrumentals, therapy, etc., I'm thinking about that risk and vulnerability. And when I talk about risk, I mean some of the obvious things like having a diagnosis that's associated with dysphagia, such as Parkinson's, head and neck cancer, stroke, etc., but also other things that may increase risk, like those things we talked about before: frailty, delirium, impulsivity, things like that. And then also we need to consider not just how likely they are to have dysphagia, but how vulnerable they are for the consequences of dysphagia, such as aspiration pneumonia and malnutrition. And when I talk about vulnerability, I mean that we can have two patients with the exact same looking swallow study have very different clinical outcomes. So for example, a patient that's relatively young, let's say 45-year-old, who is radiated for a tongue-based tumor, who has a great cough strength and is otherwise pretty mobile and healthy, if they have trace aspiration on their swallow study, their outcomes are going to be very different from that exact same swallowing profile in a patient that's a week out from a lung transplant, right? So not only are their long-term treatment recommendations going to be different because of the underlying etiology of the dysphagia, but their immediate treatment recommendations in terms of what we recommend they start eating and drinking and how they manage their immediate dysphagia is going to be very different. And I'm constantly kind of weighing those things in my mind as I go through the whole process of working with a patient to try to figure out where they fit on that scale of being really aggressive versus being really conservative. So now I'm going to talk about those specific ICU patient populations. The first would be extubated patients. And what I mean is patients who've had a breathing tube put in through either their mouth or their nose down into their larynx and trachea. Patients with a tracheostomy, so an airway that goes directly into their trachea, or patients receiving oxygen through high flow nasal cannula. And again, I'm going to spend a lot of time on extubated patients, but I think some of the things I talk about there will be applicable to just general ICU patients as well. So when we talk about post-extubation dysphagia, we essentially mean difficulty swallowing after breathing tube removal. I'll cover incidence, etiology, and risk factors, starting with incidence here. So the reported frequency of post-extubation dysphagia in the literature ranges from anywhere from 6% to 93%. So that's a huge range. And the reasons for this wide range include different participants that were studied. So looking at perhaps a neuro ICU versus a mixed medical ICU versus trauma patients, the duration of intubation that these patients had. So are you looking at anyone who was intubated for any length of time, or are you looking at some sort of prolonged intubation, either greater than 24 hours, greater than 48 hours, etc. And then other inclusion/exclusion criteria. So are you including patients that could have a history of stroke or Parkinson's or head and neck cancer, or are you excluding those high-risk patients? Also, the definition of dysphagia used. So it could be aspiration on an instrumental evaluation, it could be clinical signs of aspiration on a bedside, or perhaps need for tube feeding or diet modifications. There's lots of different ways dysphagia has been defined in these studies. And evaluation methods. So is it failing a nursing screen? Is it signs of aspiration on a clinical eval? Is it measured with an instrumental evaluation? For example, the 6% up here in this excellent study by Stacy Skortz looked at all patients who underwent cardiac surgery, including patients that were intubated just briefly for the surgery. Versus this higher percentage study by Mocht and colleagues was looking at a cohort of patients in a neuro ICU who were needing a swallowing evaluation. And so it makes sense that high-risk neuro ICU patients would have an increased risk of dysphagia versus lower risk cardiac surgery patients, even regardless of intubation. But when we look at estimates that are based on studies that used an instrumental evaluation, so arguably a more objective evaluation, we're actually visualizing the swallow function, in a cohort of patients that required a swallow evaluation, either by meeting some criteria that made them at risk or from a consult by a physician or something, not just taking all takers, the estimates range from about a quarter to a little over half of patients having dysphagia. And so I think that's probably the cohort of patients as speech pathologists that we're kind of thinking about. So why do people have difficulty swallowing after having a breathing tube in? So these categories you see listed here are loosely taken from an article by Mocht and colleagues from 2013. Now, I know technically this article is becoming a little dated at 7 years old, but it's still one of my favorites, and I would highly recommend reading it. And I like to think of these categories as sort of directly caused from the endotracheal tube. So a function of having that tube placed or having that tube in for a prolonged period of time, versus indirect, that aren't related to the tube itself per se, but a function of everything surrounding that mechanical ventilation. And that may make more sense as we go through these individually. So you can see in this picture, this is a picture of, well, a cartoon person having an endotracheal tube placed, but you can have damage to anything from the lips, teeth, tongue, pharynx, larynx, and trachea. So anything along this breathing tube placement during the act of placement, or just as a function of it rubbing against those structures for a prolonged period of time. You can have laryngeal edema, which is swelling of the voice box, and you can have granulation tissue. This is another one of my favorite studies by Rebecca Scheel and colleagues from, I think, 2016. Yeah, 2016. They looked at 59 extubated patients that were evaluated with FEES, and they found that all of their patients had some degree of laryngeal pathology, with the most common being laryngeal edema and erythema, so swelling and redness, essentially. And then the less common being those more severe issues such as ulceration and vocal fold immobility or stenosis. The caveat here is that these were patients that were intubated for over 48 hours. This may not be the same in a patient that was intubated for a couple hours for surgery. I'm going to show a couple examples of some FEES images, and these patients have consented to have their images used for education. But I just want to show you what you may see if you were to do a FEES. And I know that not everyone in the audience is familiar with looking at FEES images, but basically this is a camera that's been placed through the nose and dangled down into the pharynx or the throat, and we can watch the structures of swallowing from above. And these patients are going to be swallowing now, but you'll be able to see a close-up view of their larynx or their voice box. So I'm just going to pause it for a second. These are the vocal folds here, okay? They're what come together and vibrate when we talk. That's the sound we turn into speech. They also come together when we cough or when we swallow. So this is the entrance to the airway. Behind it is the entrance to the esophagus that leads down to the stomach. You can actually see this is a feeding tube that's coming down into the opening to the esophagus. And that esophagus is closed unless we're in the act of swallowing, or should be closed. So the patient's voicing. You can see the vocal folds are coming together relatively well, but you can also see those tissue changes at the posterior vocal folds there. And so that's presumably from having that breathing tube rubbing for a prolonged time through there. Now this patient was intubated for 4 days. So now I'm going to show you somebody who was intubated for 19 days, which is a pretty long intubation. And you'll be able to see the difference. So again, there are those vocal folds, and everything looks just a little bit more irritated, a little bit more inflamed. And then when we get down there, we can see significantly more tissue changes here, and even some subglottic narrowing right here as well. So you can see the difference in that trauma aspect depending on the duration of intubation. The next thing I want to talk about is reduced laryngeal sensation. So essentially meaning that your larynx doesn't feel things as well as it did before, which is so important for a cough response to aspiration, and also important for timing of swallowing. This is that Scheel study that I referenced before. Again, 59 patients intubated for 48 hours, and they found that 41%, so a little under half, had reduced laryngeal sensation. A separate study that did both FEES and cough reflex testing within the first 24 hours of extubation found reduced cough reflex in the extubated patients. However, the reduced cough reflex did not correlate with aspiration. The third mechanism of direct trauma from an endotracheal tube includes compression of the recurrent laryngeal nerve, or the RLN. Now, for those of you not familiar with the recurrent laryngeal nerve, it's a branch of the vagus or cranial nerve 10 that innervates the larynx and helps with voicing and cough. It actually, I mean, this is somebody's larynx right here in their trachea. So it starts way up top, obviously coming out of the brainstem, but then it actually loops under the aortic arch on the left and the subclavian artery on the right, and then runs alongside the trachea before innervating the larynx. So if you have a cuff, so that's a balloon that's inflated around the endotracheal tube to prevent air from sneaking out the sides, so that when they're ventilating people, the air is going just in and out the tube, no escaping. If that cuff, which sits about here, becomes overinflated, it can compress the recurrent laryngeal nerve, causing usually a transient damage, but a paresis or a paralysis, so meaning either reduced or absent movement of the vocal folds. This is an example of a 30-year-old woman intubated 8 days, and she's doing some tasks, some sniffing and voicing tasks, and you can see that this arytenoid, right, on the left side of the screen, right side of her body, is moving more than this one on the opposite side. And that was believed to be due to compression of the recurrent laryngeal nerve. This is a review article by Dr. Brodsky, who does a lot of research on intubation. He looked at 9 different studies with a total of 775 patients, and they found that 83% had laryngeal injury after extubation. However, most were mild. And the patient-reported symptoms, you can see the most commonly reported symptoms were dysphonia, which is changes to your voice, and pain, but about half of the patients complained of difficulty swallowing. So, I mean, I guess I'm assuming if you're tuning in, you're kind of already a believer, but I guess I'm just trying to convince you that this is a real thing. This is more common than I think people realize. And the reason I have this little coronavirus symbol here is because there's been some chatter on sort of message boards and such that perhaps there may be increased risk for laryngeal trauma for patients who are being put in the prone position, so placed on their belly here, as part of their treatment for COVID-19. One thought is maybe that's more shifting of the endotracheal tube as they're turned and rotated, although we don't really know. There's no research on this, and certainly prone positioning is not a new procedure. I've seen it used for other patients, like with bad influenza. But a lot of these patients are being put in that position, and it may increase their risk for trauma to their larynx. We don't know, but it's something to kind of keep in the back of our mind. Now, there are other causes besides those direct causes from the tube. So it's not all just the tube being placed in there. There's also the impaired sensorium, which we really touched on earlier, but these patients can have delirium, they can have changes because of medications, and they can have metabolic dysfunction impacting their thinking. And then they also have deconditioning. So when the tube is in, they have reduced or absent swallowing. And we talked about that ICU acquired weakness. Now here's that study I said we'd circle back around to. This group did a measured tongue strength following intubation, and these people had a fairly lengthy intubation, so the mean duration was 8 days, and they found that the extubated patients had reduced tongue strength compared to controls, again perhaps suggesting that there's something to be said for this disuse or this deconditioning of the swallowing musculature. So now I've convinced you that dysphagia following extubation is a real thing. We've talked about why it might occur, but we want to know, are there certain patients that are more at risk for us? And this is so relevant, or not at risk for us, at risk for dysphagia. And this is so relevant for a speech pathologist planning our evaluation and treatment. So this is a list of factors that have been in at least one study evaluated to see if there's an association between the factor and risk for post-extubation dysphagia. You can see some of them have to do with the patient's sort of pre-admission features versus things that are directly related to their reason for admission, and then factors that are related to the actual intubation. The ones listed in red here have been shown in at least one study to have an association with dysphagia following extubation. Now, I'm not going to talk about all of them, but I will talk in a little bit more detail about these 3 because they kind of come up in the literature over and over and over again. So the first one is, does risk for dysphagia increase with age? And this is a list of studies here that have at least sort of looked at that or mentioned it in their study. Maybe not as the primary outcome, but the ones listed in red, they did find that patients who were older were more likely to have dysphagia post-extubation. Now you can see it's about half of the studies. There doesn't seem to be a pattern with sample size or the evaluation method or the type of population, so it's hard to know why some studies found a difference and some didn't. So the question we have is this still very handsome Han Solo on the left here, equally at risk for dysphagia as his younger self if he were to crash the Millennium Falcon and end up intubated in the ICU? My short answer is probably. The long answer is it's complicated, and I'm going to try to convince you of that near the end of the presentation, that it's not just one factor, but it's a lot of factors swirled together. As a side note, when I think I was a clinical fellow, Harrison Ford crashed his plane in California, and it was in the news, and I thought, ooh, I wish I could be his speech pathologist, but we don't get any celebrities in Madison, Wisconsin, so what are you going to do? So the next thing is, does risk for difficulty swallowing increase with duration of intubation? And this is a list of studies that, again, have looked at that, and the ones in red did find that patients intubated for a longer period of time were more likely to have dysphagia. They're listed alphabetically here, but if I reorder them by sample size, you'll see that it's the studies that had the larger sample sizes that, for the most part, found the difference, and it's possible that they were powered well enough to find these differences. Another theory is that the relationship between post-extubation dysphagia and duration of intubation may not be linear. So this is another paper by Dr. Brodsky, and they looked at 132 extubated patients with acute lung injury, and they measured dysphagia by a questionnaire, and they found that there was an increased duration of intubation was associated with dysphagia, but only for the first 6 days of intubation, and then it plateaued after that. And so one theory is that, again, this relationship may not be linear, that the difference in risk between being intubated 2 days versus 5 days is much more different than the risk being intubated 10 days versus 13 days. The way I think of this is you probably reach a point of duration of intubation where you're just high risk for difficulty swallowing, sort of most likely that you will have some difficulty. The question remains is, where is that cutoff point, right? Is it 48 hours? Is it 5 days? Is it a week? We just don't know. The next thing I want to talk about is emergent intubation. So this study found that patients admitted for an emergent admission were twice as likely to fail a nursing screen. Dr. Leader found that 4 out of 5 patients with traumatic intubation aspirated on fees. And the Shield paper that I've referenced now for this third time here found emergent intubation to be associated with penetration and aspiration on fees. And the theory is that maybe when you're intubated in an emergent situation, there's less control, or more things could kind of go wrong, and potentially more trauma to the structures that are so important for swallowing. So now I'm going to talk for a very short period of time about tracheostomy, but I will also give you some additional resources on it, even though I'm going to talk for a short period of time. So a tracheotomy can be performed for a variety of reasons. The most common are airway obstruction, so meaning that there's a blockage of the airway upstream from the tracheostomy, so breathing through here is more efficient, or need for prolonged mechanical ventilation. And I would say in our ICU, that's the most common, is the need for prolonged ventilation. These airway obstruction folks are not generally in the ICU. I want to also make it clear that tracheostomy tubes do not cause dysphagia. I think sometimes there can be a misconception that that's the case, but it's the other stuff associated with the tracheostomy. So if you do a swallowing evaluation on a patient with a large laryngeal tumor who has a trach, it's more likely to be the laryngeal tumor than the actual tracheostomy tube itself. The same goes for a patient that's been ventilated for a long time. It's not the tube's presence that's causing the problem. It's the fact that they haven't eaten in 2 weeks and they're very deconditioned and their breathing and their swallowing are uncoordinated. It's probably something along those lines. That being said, patients with tracheostomy are at elevated risk for silent aspiration. And I'll talk more about this when we talk about silent aspiration in the ICU in general. So like I said, I wasn't going to talk about it for very long, but this is another article by Stacy Skoritz that I would highly recommend reading if you want to know more about the current research in dysphagia with tracheostomy. I would also direct you to another free online presentation given by 2 of my now former colleagues who I miss dearly. Jamie Mayer and Katie Huber gave an online lecture on tracheostomy and dysphagia, and it's available to watch for free at the Voice and Swallow lecture series. It's currently not available for CEU, but you can still watch it anytime. So that was my portion on tracheostomy. Now I'm going to spend even less on high flow nasal cannula. So a high flow nasal cannula delivers both heated and humidified air. It allows for independent adjustment to the FiO2 and flow rate. There is there's a lot of debate on how much PEEP or how much pressure the oxygen flows with. The concern being, could it be blowing food or liquid into the airway? Now that varies depending on the settings of the high flow, the patient's body habitus, and also whether they're breathing with their mouth open or closed. There is also limited research, though, on its impact on swallowing. Dr. Leader published a paper on high flow nasal cannula in both the little babies and also the adults. And you can read that paper, but they did find that there were patients that could safely swallow on high flow. Now, I don't necessarily I should say, kind of like how I think about tracheostomy is, I don't think it's the high flow itself that causes dysphagia if you have a patient with difficulty swallowing on high flow. I think that high flow is a marker of something else, right? It's a marker of a tenuous respiratory status. And so I think about it not necessarily as a risk for dysphagia, but as a marker of increased vulnerability for the consequences of dysphagia. Oh, okay, so it's Elizabeth, I'm taking a brief intermission here, so you can give me some questions to answer.
Excellent. So if anybody in the audience has questions, feel free to type those in. I have a couple already, Stevie, that I will ask you.
Hey, I hope I can answer them.
Yes, let me know if you want to save any of them until the end or the second half of your presentation.
Sure.
Question about edema. How long does it take typically for the edema, for the swelling to go down after extubation?
I don't think we really know, and I think it probably varies patient to patient. So I will have a little bit of comment on how in the future slides on how swallowing changes after extubation, which may be potentially a surrogate marker for that. But I suspect it depends on the patient's overall, the level of trauma they experienced, right? So how bad the edema is, and the other things about the patient's immune function. So there's some concern that, patients perhaps with things like diabetes and stuff may take longer to recover. But to my knowledge, there's been no actual research showing it how long that takes to resolve. Okay. So I gave you kind of a politician answer on that one, sorry.
The next question that I have for you here, it says, with respiratory compromise in patients that are intubated, why do they not place these patients upright? It's a comment from somebody that has asthma, and she says that the last thing that she would want is to be supine or on her stomach.
Oh, okay. So I can say a little bit about that, but I'm not a critical care physician, so it won't be the most informed answer, but the prone positioning is used in very, very serious respiratory conditions, and it has to do with helping the lungs ventilate better. Beyond that, I can't explain it any better than that. But for your regular sort of garden variety intubation, at least in our facility, they do typically have people at least semi-upright all the time. To reduce risk for a reflux coming back up. And then when possible, they're getting our intubated patients up into a chair, maybe not a traditional chair that you stand up into, but either a bed that goes into a chair mode or sliding them over to what's called a cardiac chair where they can actually sit up while they're on the ventilator. And so that is a more commonly, or being prone is much less common than being in either a semi-upright or upright position.
Another question here for you. Do you have suggestions for managing dysphagia in patients that have chronic COPD who are also on high flow?
So yes and no. So I think about COPD and high flow nasal cannula as both being sort of markers of how vulnerable a patient is for getting aspiration pneumonia or having a consequence from difficulty swallowing. So my advice, and may not be possible in every facility, is I like to get direct imaging for these patients so I can understand, one, what types of things they're aspirating, either consistency wise or bolus size wise, try different postural strategies based on what the swallowing study looks like, instead of just flying blind, because we know that patients with COPD, even small amounts of aspiration can yield very devastating consequences in terms of decline in respiratory status or pneumonia. So I like to image those patients, and then that gives me a better idea of how to treat it, both long-term and short-term.
Next question here is a common one that I have seen as a rehab SLP. What is an appropriate amount of time to allow for organic vocal fold healing post-extubation prior to involving ENTs?
Ooh, excellent question. And I think it varies facility to facility. So, and this is such a tricky one to answer. So when I have a patient who's been extubated and they have a very breathy voice or a very weak cough, I like to choose FEES as my evaluation method so I can lay eyes on their vocal fold mobility. And certainly I'm not going to diagnose a paresis or a paralysis, but it gives me sort of more justification for involving an ENT. Now, every ENT approaches this differently, but there is some evidence to suggest that getting a vocal fold medialization injection for patients with an immobility or a hypomobility can improve swallowing in the short term. And so if you do your FEES exam and they have good movement and things just look kind of swollen and irritated in there, there's probably not a lot that, and they have a good airway, there's probably not a lot that an ENT will do. But if you see some asymmetry in that movement, it gives you justification to get them involved right away. And even if they look at it and they say, well, this is more of a wait and watch scenario, I think that should be their judgment to make, not ours. So I hope that kind of answered the question. If you're at a rehab facility and you don't have any access to imaging, I would say if a patient is a ways out from extubation, so like more than a week, and their voice and swallowing improvement has plateaued, I think getting that ball rolling, because it's not going to be that they're going to be seen by ENT most likely right away, but getting that on somebody's radar that this needs to be looked at.
Stevie, we have tons of questions
Anything
coming
else,
in.
Elizabeth?
I'll ask you one more, and then a lot of the questions are about timing for evaluation. Yes, let me ask you one more question here, and then I'll let you
don't worry,
continue
I'm
with
getting
the
to that.
second part here. The question is, have you seen any dysphagia? Yes, any dysphagia-related issues to patients lying prone, especially pertaining to reflux? Have you seen any tissue damage related to reflux while somebody has been intubated?
So to be fair, I've seen very few patients in my career that have been prone for a prolonged period of time. The ones I can think of were, young, intubated for a really long time for influenza. And I mean, they were intubated a really long time. So, I mean, their larynxes look pretty awful, but it's a question of, is there reflux? Is it the tube? We don't know. So hard to know. I will say that most of our patients that get a feeding tube placed when they're intubated have the feeding tube placed post-pyloric to try to limit reflux.
Stevie, I'll let you continue, but for the audience, feel free to keep sending in your questions. We probably won't get to all of your questions, but I will send them to Stevie after the presentation.
All right, so I just keep going again, right, Elizabeth?
Yep, go ahead.
I'm gonna just keep going. All right, so now, go ahead. The scenario is now that there's a consult placed on a patient in the ICU, and we as speech pathologists have to decide what's the best evaluation methods. So we have lots of things in our SLP toolbox. The first being clinical evaluations, which I'll talk about in more detail, but it's essentially a subjective assessment done at the patient's bedside, usually watching them eat and drink, possibly with some palpating of their larynx. The second is video fluoroscopic swallow studies. So that involves having a patient swallow various consistencies of barium while we take X-ray video that can be reviewed not only in real time, but afterwards in frame by frame or slow motion to evaluate for dysphagia and the underlying etiology of the dysphagia. And then we have fiber optic endoscopic evaluation of swallowing, which I've already been talking about a lot, called FEES. And that involves placing a skinny little endoscope through a patient's nose and then down through their throat to visualize the tissues of the larynx and pharynx while they are swallowing. So what we choose depends on the patient's characteristics, their symptoms, and also resource availability. And this choice may be influenced by COVID-19 isolation precautions and or a surge in patients with COVID. And so I'll talk about that as we go along here. Apparently, I really wanted to emphasize that. The other question we have to evaluate, which I'm guessing is something that's hot on people's minds here, is when to evaluate these patients in the ICU. So if you work in the ICU, this looks probably like a familiar statement. The question is, should patients be evaluated immediately post-extubation? Should we wait 12 hours, 24 hours, 48 hours? How long after tracheostomy do we have to wait? And does it depend on the patient? And does it depend on COVID, right? So this is a study that we completed at UW-Madison, just trying to sort of get at answering that question, at least a start. So we completed FEES exams on patients 2 to 4 hours post-extubation, and then repeated the exam in that same patient closer to that 24-hour time point. We had included patients that were intubated for 48 hours with no history of dysphagia or condition that would be likely to cause dysphagia. And you can see that not everyone completed both exams, either because they had a functional exam at the first exam or because of other reasons such as reintubation or decline in status. Of the patients, of the 68 patients that had an early FEES, 57% aspirated, so over half, but over half were cleared for an oral diet and almost a quarter of them were cleared for an unrestricted diet. When we compared that early FEES result to the later FEES result, 80% had improved airway protection on at least one consistency. So for example, at the early FEES, if they were aspirating, let's say the mildly thick liquids, at the second FEES, they were not. About half of them advanced their solid diet and about half advanced their liquid diet. So you could interpret this study in a lot of different ways. On one hand, some people see this and say, over half of the people were cleared for an oral diet at that 2 to 4 hours. There's no reason to put off doing a swallowing evaluation in a recently extubated patient. On the flip side, the fact that 80% improved means that perhaps waiting a little longer will yield better outcomes for the patient. So less restricted diet, more functional swallow, etc. My interpretation of this is that we still have to take it on a case-by-case basis, which I know people don't really like to hear sometimes, but I like to reserve my early evaluations for my lower risk patients, and for my higher risk patients, encourage, if possible, postponing that evaluation until closer to 24 hours. That being said, if I'm getting called by a doctor or a nurse requesting an evaluation the same day as extubation, I like to go lay eyes on the patient, and maybe they don't look ready to me to start eating or drinking, but I can at least weigh in on how to safely take pills if they don't have a feeding tube. Or I can give that patient who's been begging for water since the breathing tube came out, we can do ice chip trials or swab trials, and they can meet me and I can explain the rationale for waiting to do their full evaluation tomorrow. And sometimes, not always, sometimes that's enough to help patients sort of get by for that short period of time and understand that someone's coming and that there's a plan in place. So if people have more questions about that, I'm happy to talk about that at the end for questions. So clinical swallowing evaluation, that's one of our pieces we have in or one of our tools we have in our toolbox. It involves a really thorough case history, an interview with patients and families, if possible, assessment of mental status, a cranial nerve exam, or at least the best one you could get. Some of these ICU patients, you may have to maybe limited to stick out your tongue and cough, but you do your best if they're delirious to get the exam you get. Assessment of vocal quality, which is particularly relevant for recently extubated patients. And oral trials. And oral trials can be as simple as ice chips in some high-risk patients, or it can be the full gamut of textures. With those trials, I'm looking at efficiency of swallowing and trying to assess their aspiration risk as well. But what about silent aspiration, you say? Well, let's talk about silent aspiration. So this is a list of studies. The top table here are recently extubated patients, and these bottom two are patients with tracheostomy. And you can see that there is a very wide range of frequency of aspiration and wide range of frequency of silent aspiration, anywhere from like 10% silently aspirating to 50%. And that difference, again, is all those things we talked about before in terms of how these studies were differently designed. Tracheostomy patients, though, you can see that silent aspiration is 1/4 to half of the patients. As a result, our facility, our best practice guidelines is all patients with a new tracheostomy will get an instrumental evaluation before starting their oral diet, with some very, very rare exceptions. So you ask now, are there specific patient factors that we can watch for that may increase that risk for silent aspiration? So either nudging us over the edge to do the instrumental eval or making us confident that we can go on our judgment clinically at the bedside. One of these is age. So this study looked at 84 patients, and they had half of the patients in an elderly group versus a control group that was younger. And they found that there was a significant difference in the frequency of silent aspiration. So 19% of the older folks versus 7% of the younger folks, suggesting that older folks are more at risk for silent aspiration. The paper that I referenced before, where our primary outcome was looking at those changes over time post-extubation. We also looked at different factors, patient factors, and the risk for silent aspiration. Our study also found that older folks were twice as likely to silently aspirate. Pre-admission diagnosis of COPD, which ended up being mentioned in one of those questions, they were at increased risk for silent aspiration, as well as admission for liver disease and trauma. We did have limited sample size because this was not our primary outcome, so take these results sort of with a grain of salt, but I think that, you know, we have other evidence from previous research that age is a factor, and we know that patients with COPD are both at risk for dysphagia and for silent aspiration. Now, this is another study that I wanted to talk about at some point during this talk, and it's one I wanted to use my notes on so I don't say anything silly here. And I think it goes here. So this is that group from Colorado that I've referenced before, but they did both a bedside swallowing evaluation and a FEES in patients that had been extubated. Their bedside swallowing evaluation, the trials varied depending on the speech pathologist's judgment, but you can see them listed there. And then a portion of them received a 3-ounce water swallow test or a 90 ml challenge. And they found that 31% of patients aspirated on the FEES. 18 patients were recommended for a regular diet based on the bedside eval that then subsequently and 2 of those, subsequently aspirated on the FEES. 27 patients were recommended for a modified diet, and 12 of those aspirated. I have a little star there because the paper doesn't necessarily say if those patients aspirated the consistencies they were recommended for, or if they were tolerating the consistencies they were recommended at the bedside. They found that the 3-ounce water swallow test was the most sensitive for identifying aspiration, with a sensitivity of 77%, meaning that large water swallow test correctly identified 77% of aspirators. But that means that almost 1/4 of the people did well on that and then did aspirate on the FEES. Puree had the best specificity, meaning it was the best at identifying patients without aspiration. So the authors concluded that a clinical swallowing evaluation is not sensitive enough in patients that are recently extubated, who were intubated for respiratory failure. Now, I would actually agree with this, but I think we have to be careful not to throw the baby out with the bathwater, right? It's tempting to say, well, then let's just give everyone an instrumental eval post-extubation. But I think that there is a role for the clinical swallowing evaluation in the ICU. And this slide's going to get a little opinion-y, but I guess this whole presentation's been a little bit my opinion, hopefully justified with research, but my opinion and my approach. And that is that the clinical swallowing evaluation helps us assess risk for dysphagia, helps us determine readiness for a diet versus instrumental evaluation, and helps us plan when that should happen. And if needed, what's the best type of instrumental evaluation? So the question in the ICU is not to be or not to be, it's to image or not to image. I hope somebody's laughing every once in a while when I think I'm being funny here. It's so weird because nobody's in the audience, or for me, no one's in the audience. So what influences that decision to recommend an instrumental evaluation? Risk for dysphagia. So I know I've said that lots of times. So risk factors that the patient has, and then also clinical symptoms of dysphagia. You can get a consult on somebody who's 25, who was intubated 2 days, and you think, well, they should be fine, but you go to the bedside and they're gurgly when they're swallowing, so they should probably have an instrumental evaluation. And vulnerability for the consequences of dysphagia. So I know I keep bringing it back to this lung transplant example, but sort of our best practice guidelines is we do see lung transplants at the bedside, but it doesn't matter how good their swallow looks, they're being imaged before they start their diet. And that comes from literature, but it also comes from our thoracic surgeons telling us that any aspiration can be devastating for these patients. So constantly throughout our whole process with these patients, it's weighing all of these things, and those things can tip you over the edge to being conservative versus more aggressive, and unfortunately there's not a recipe for it. So a little bit more on risk and vulnerability. When I think about risk, I think about the older folks are more at risk, patients with longer intubation more at risk, those comorbidities that are associated with dysphagia, and then concern for trauma as part of the intubation or extubation process, but also vulnerability. So thinking about, do they have a tenuous respiratory status? Are they frail? And what's the function of their immune system? So if are they high risk for getting an infection? So now let's say you've decided a patient needs an instrumental eval. Let's put our two choices, our fees, so the scope through the nose, or fluoroscopy or video fluoroscopic swallow steady, the x-ray. Let's put those head to head and decide which one we should choose. Spoiler alert, there's not one right answer. So this here is a list of factors or things that might be of interest to us when selecting an evaluation. And we're gonna go through each of these individually and say how these evaluation methods match up. So both fees and fluoroscopy can identify timing of swallowing. They both can identify aspiration and that elusive silent aspiration that we're also worried about. They both can identify pharyngeal residue, which can be really helpful for us in planning strategies and planning diets. They both, only a FEIS can visualize the tissues of the larynx and pharynx, which can be relevant in certain patient populations, such as a recently extubated patient. And only FEIS can visualize vocal fold mobility, also can be relevant for a recently extubated patient or any patient that's had surgery to the neck or chest where you have concern for damage to that recurrent laryngeal nerve. On the flip side, only fluoroscopy can really assess the upper esophageal sphincter and cervical esophagus. Now, I know what you're thinking here. It's not a common problem of swallowing in ICU patients. But I've seen patients who I'm seeing them, let's say post-extubation, and they're having some difficulty swallowing at the bedside, and the wife chimes in, oh yeah, he can cough up solid food or a pill even an hour after he's eaten. And that's been going on for, 6 months, a year. So that may tip you over the edge to wanting to look at that upper esophageal sphincter and cervical esophagus in that patient. Now, we know that the radiation exposure that we use for our X-ray swallow test or our video fluoroscopic swallow study is small, but some of these ICU patients are going to need several exams over a short period of time because they're rapidly changing, rapidly improving perhaps. And so I do think it's relevant to at least consider radiation exposure, and FEIS there is no exposure. These can also be performed at the bedside. We do not have the ability to perform video fluoroscopic swallow studies at the bedside, and I think that many facilities don't. There are some who will bring a portable C-arm to a patient's room, but I think most commonly all of those exams are done off the unit in radiology. And this can be, being performed at the bedside is more important for ICU patients because they have a lot of equipment generally. So they may be on oxygen, they may have chest tubes, different lines, that kind of thing. And they need a nurse to travel with them for the exam if they leave the unit. And while a patient may be individually safe to transfer out of the unit, when we take a nurse out of the unit, it means that there's fewer nurses in the unit to care for the remaining patients. And that can be perhaps a safety concern for the unit, not necessarily for the patient. So I think being performed at the bedside is a plus. Flexible timing. And I think this is relevant for ICU patients because these are patients we're often getting a consult on when physicians and nurses and the patient are hoping for a quick answer. It's not the same as a patient who came in to the hospital, is being allowed to eat, but there's some concern for difficulty swallowing and they want an evaluation while they're here. These are patients that are most often not being allowed to eat or drink until we see them, or perhaps not even being allowed to take their medication. So it's important that we can be flexible with our timing. And you put well tolerated here because I think there's a misconception that having a scope put in your nose is not well tolerated. And that's true for some people. But if someone is skilled at placing the scope, most people tolerate it really well. And I would argue that ICU patients, particularly recently extubated patients, tolerate it better than even our outpatients because they are used or they've already had experiences with tubes and they may be desensitized to the tube. So now I want to give just a little update on instrumentals during the pandemic. So the American Academy of Otolaryngology released a statement in late March advising limiting ENT procedures, so including our stroboscopy and our fees, to time-sensitive and emergent problems. And this was because some of the early COVID data showed that ENT providers were at high risk for contracting the virus and high risk for dying from the virus, possibly due to the aerosolizing nature of their procedures. So the UW Health's current approach to endoscopy as of today, May 11th, is while we initially stopped all fees in stroboscopy regardless of COVID status, we are currently allowing outpatient urgent stroboscopy and fees in patients who've had a negative COVID test within the last 48 hours. And we have recently restarted fees practice with our inpatients with a negative COVID test because everyone is being tested upon admission. And then I want to talk about sort of our general approach to managing our patients with COVID-19 here too, not just instrumentals, but we are currently treating or evaluating our patients with COVID exclusively with clinical evaluation. And these clinical evaluations are completed via telemedicine. So there's a bedside tablet that's used, and then we're on a laptop, and we can see the patient and hear the patient through there. We're trying to coordinate the timing of our evaluation with the nurse or nursing assistant when they need to enter the room for another reason. And these approaches to both conserve PPE or personal protective equipment, but also limit staff exposure to COVID or to coronavirus. Some exceptions have been made for general care patients that are COVID positive, so less likely, lower risk for transmission, who cannot actively participate in an evaluation via the video. So, for example, a patient with severe dementia who just can't attend to the video. Instrumental evaluations are not allowed for patients that have COVID until they've had a negative COVID-19 test. So, you know, this is a very different approach to managing dysphagia in the ICU. I'm very fortunate that for years and years and years, I've had the luxury of being able to just grab my fee scope whenever I had a concern, or grab my fee scope whenever they wanted a high-risk patient to start eating and drinking shortly after extubation. And now we don't have that luxury, at least currently. It may change. So these patients are being started on diets much more slowly and much more conservatively. So they are not being evaluated the moment the breathing tube comes out. We're pushing those evaluations out to 24 hours, in some cases longer. We're starting very, very slowly with sometimes very, very limited amounts of restricted textures, and then advancing as they tolerate them. So it's for me, it's a very different approach, but so far it has seemed to be working. And it's not the only approach there. I've read that other facilities are allowing some COVID positive patients to go for swallow studies. UW Health approach is currently not allowing that. Some other considerations for patients with COVID-19, there's concern for tenuous respiratory status, even in patients that have not been intubated. A lot of these patients that are intubated for a long period of time. So we're not talking days, we can be talking weeks And we don't know yet if extubated patients with COVID-19 are at higher risk for aspiration or at higher risk for silent aspiration. We can look to those risk factors from our general data about extubated patients, but we really don't know if there's something different with this virus. And we have, like I said before, limitations in our evaluation options. So we're having to get creative and shift how we manage patients. And I think that, you know, we're learning so much about this. I always joke that the barium shortage of 2013 taught me so much about fees. And I think that this pandemic is going to teach us all so much about telepractice and what we can and cannot do via telepractice. So it's still a learning process. So I'm going to transition to talking about treatment. We're in the home stretch, everyone. This is a really sophisticated treatment technique that I use. It's called functional practice. So especially for acute care patients or ICU patients, I like to find, even if it's one texture that they can swallow safely, even if it's half spoonfuls of mildly thick liquid with a chin tuck, anything I can get them doing to resume swallowing in a safe way is a thumbs up, if you ask me. And I think patients enjoy this approach because they are eager to start eating and drinking. So it's motivating for them to participate in. My other really sophisticated treatment technique is giving them time. So we know that patients do improve just spontaneously with time. And so you may see somebody who is not ready to eat or drink anything, and they may need a little more time to just breathe, to let some of that trauma that they've experienced in their larynx and pharynx to go down, to let some of those medications leave their system, to get delirium to improve, those kinds of things. And whenever possible, combining functional practice with time is a good technique. And exercise. So finding exercises that are targeted to the patient's deficits is always preferable. But any exercise that gets them doing some swallowing, perhaps with utilizing extra effort or in a more structured way, can be beneficial, because the best you know, it's sort of a lose it or use it. The best treatment for swallowing, in my opinion, is swallowing. This is a study that looked at the effectiveness of therapy on recently extubated patients. And these patients, that was a very small sample, so only 15 patients, and they underwent therapy for 5 days and had some pre and post measures trying to get at their dysphagia. And they did find that the patients had a reduction in clinical signs of dysphagia and improvement in their EMG measures. However, there was no control group, and we do know that patients just improve spontaneously or can improve spontaneously with time. So it's hard to say whether it was the therapy that helped them improve, if it was time, or if it was a combination of the two. But I think this is a really great area of future research. So I'm gonna just do a quick case example here of a 41-year-old female who was admitted for respiratory failure due to the flu. She was intubated 8 days. We got a swallow consult approximately 18 hours after extubation. Happened to be a Friday morning. Now, I went and saw her at the bedside, and already kind of coming into it, I'm like, oh, she's young. We got a thumbs up there. She was, and then I walked in, she's sitting up in a chair, she's on room air. Her voice is a little hoarse, but she's cognitively intact, no neurodeficits in her cranial exam beyond the like mild hoarse voice. And I thought we're gonna get this lady on a diet today. And then I gave her some oral trials, and she kept having this intermittent wet voice. And I thought, well, all right, we'll get the fees cart. And this is a picture of her airway. So again, here are the vocal folds here. And she has some pretty significant granulation tissue in her subglottis there, and some narrowing. So some trauma from her endotracheal tube. This is probably why her voice is hoarse, right? And then here are some images of her swallowing. And at our facility, we use white products, so milks and vanilla puddings, because the white catches the light. So that was a swallow, and that one looked pretty good. Here she's going to take another swallow, and so I'm staying kind of far away from her airway while she's swallowing, so that she doesn't no interference from my camera. And then there she's swallowed, and we're going to go take a look. And you can start to see there's just some whiteness here, and I have her cough, and you can see that milk is coming back up. So she's getting milk into her airway. and having a hard time coughing it out. So overall, her results, she had silent aspiration, although small amounts of all the liquids, and trace supraglottic penetration, meaning kind of penetration in this area here with puree. But she was pretty, even though she's in the ICU, pretty functional patient. So I gave her an assignment to do 4 ounces of puree 3 times a day over the weekend just to get some practice swallowing. And then we planned for a repeat evaluation after the weekend just to give her some time to heal. And this is her exam Monday morning. And now we're doing a fluoroscopy to get an alternate view. So you can see she had a little delay in the onset of her swallowing there. But for those of you not familiar with these images, this spine, it's a lateral view, mouth here. This white colored column is the trachea that leads down to the lungs. And then she's swallowing some barium. And you can see no barium entering her airway, which is excellent. And here she is swallowing a more viscous bolus. I believe this is a puree. And again, really nice bolus clearance. So she was advanced to a regular diet and did really well. And that was the end of it for her. And so her, treatment approach wasn't real sophisticated, but I like to think that I helped keep her safe swallowing over the weekend and gave her something to practice so that we could allow her time to heal and then advance on her own. So here are takeaways, hopefully takeaways from the presentation. So these patients can be at elevated risk for dysphagia and more vulnerable to consequences of dysphagia. Recently extubated patients and tracheostomy patients are at elevated risk for silent aspiration, and that risk and vulnerability should be considered during our evaluation and treatment. No single approach works for all ICU patients. It would be great if it did, wouldn't it? And sometimes the simple treatments are the most effective in that immediate dysphagia recovery period. And so now I'll let Elizabeth take over again and answer any questions. And just also I want to say thank you for, I'm really thrilled that so many people tuned in to watch today. I hope that you found this helpful, and I welcome any feedback, especially since this is my first time doing sort of an online webinar, and because it's a pandemic, maybe not the last time. So thank you.
Stevie, thank you so much. We have tons of questions coming in. We won't get to all of them, but I will send them to you afterwards. I'll cover a few here. My first question, I'm going to combine 2. 1, do you automatically get consulted anytime somebody is extubated? And if not, is there a nursing swallow screen that you prefer or recommend?
So I'll answer that question while I also get my article out of my favorite screening technique article. I have my stack right here, brought it down to the basement just in case. Our hospital currently does not have a automatic screening process for extubated patients. I sincerely wish we did, but we don't. So it's taken on a case-by-case basis currently. So we don't get consults on every patient, but I will say our critical care physicians really respect what we do. So we do get consults on a huge amount of them. Now, there's a lot of research on screening in the ICU. I almost put a little section on it in the talk, but I just didn't really feel like I had the time. And there's debate over who should be screened and what type of screening should be used. Let me see if I can find my favorite one here. If not, I can email. I'd be happy to send this. There's one I really like that's been published that has the reason I like it is it's got some sort of automatic fail criteria. And I don't think I'm going to find it right now. I'm not going to find it right this second, but it's got some automatic fail criteria. So if you are meet certain criteria, you just shouldn't even be screened by a nurse, right? The big one that's been studied most recently is the Yale swallow protocol, or the 3-ounce water swallow. And there is, depending on which paper you read, some evidence that that is effective for recently extubated patients, but still to be determined. I don't know, Elizabeth, if there's a good way for me to get that person the answer on my favorite screening afterwards, but you can let me know.
Yes, I can do that. Excellent. The next question I have for you is, when you do fees on inpatients, are you using lidocaine or any type of numbing spray?
We don't typically use lidocaine for any of our, I shouldn't say that. We don't use the spray lidocaine for any of our fees as part of our standard protocol at UW. We do sometimes put a little viscous lidocaine in the nose, particularly for outpatients, but not typically for inpatients. Dr. Langmore has several papers published on sort of what's the safe dose of lidocaine to use, so you could certainly reference her work there. But I find that I don't really notice that I need it. We use Surgilube on the scope to help it glide, and then fees, if you can stay along the floor of the nose, it's typically much more comfortable. And for fees exams, there's no reason we would need to be up in those upper turbinates to get any additional information. So I find most patients tolerate it really well. In fact, I had one patient who had both fees and a video fluoroscopic swallow study, and he had to come back for an outpatient one, and he requested the fees because he preferred it. So.
And right now with the urgent fees that you are performing on patients that have tested negative for COVID, are you still wearing PPE? And if so, what type?
So I will tell you what we're doing, but I want to be really clear that you shouldn't take any PPE recommendations from me as a speech pathologist. You should talk to the infection control people at your facility. But UW Health is having us wear PPE for actually any interaction with any patient all the time. So we wear a barrier mask, so not an N95, just a barrier mask, and then a face shield. And so that's what we're doing for our these exams. And quite frankly, what we're doing for our bedside evals, for our swallow studies, everyone is getting that same PPE.
Do you think once the pandemic is over, will we shift back to performing fees without any sort of face coverings?
Oh my gosh, such a good question. And I don't know. I mean, I think that that question is on everyone's mind, not just about fees, but I mean, are we going to be wearing face coverings to the grocery store forever? I don't know. So I would defer, I'm always going to defer questions about PPE to the infection control people because they know so much more about how things are transmitted, and I look to them for guidance on how we should go forward with that.
Excellent. I have a couple more questions here for you. Besides the lung transplant patients, are there other patient populations at your hospital that the physicians order swallow studies for automatically?
So actually, the way we have a lot at UW, we have a lot more leeway probably than other facilities. So physicians just put in what we call a swallow consult, and then the speech pathologist decides what type of evaluation to do. And we've just had meetings with our transplant physicians, and they have requested that we always do instrumental evals, and we were advocating for that as well. So they don't place any different order than any other physician. They put a consult in, and then as part of our best practice guidelines, we always do an instrumental. And I would say lung transplant, that's part of our best practice guidelines, so not a policy, but just our personal or our team's best practice guidelines, and also for tracheostomy patients. Other patient populations, it's taken case by case basis, looking at just sort of the patient as a whole.
And then one last question here for you before we run out of time. What is considered prolonged intubation? Is there a definition?
That's a great question, and nobody can decide. So if you look at the literature, a lot of literature will reference 48 hours as being prolonged intubation, but then some other papers will call it 5 days or longer. A few papers consider 24 hours to be prolonged. Again, I don't think we know, right, exactly when that risk for dysphagia in terms of duration of intubation becomes significant enough. I will say that I've seen patients intubated for 24 hours who have difficulty swallowing. I've been shocked by patients who've been intubated a week and their swallow looks fine. So I think that we have to take it case by case, but I generally consider anyone intubated 48 hours or longer, I'm going to start putting that in my mind as maybe a risk for some difficulty swallowing. Now that risk is going to be different in somebody intubated 48 hours who's 25 and was intubated after a car accident with no head injury versus somebody who's 75 and they have COPD and they had a big surgery that didn't go well, or something like that. So it would be so great if we could just plug all these factors into some sort of algorithm that would be like high risk, low risk, but we don't have that. We just have what we've got up top here.
Stevie, thank you so much. To those of you that asked questions that we did not get to, and I know there's many, we will do our best to respond to you through email. I'll reach out to you in the next week or so. This presentation was also recorded, so if you missed any part of it, it will be available within the next week. Stevie, I'll take the presentation screen back from you here, and then Ed's going to sign on just to wrap things up a bit. Thank you.
Hi, Stevie. Can you hear me?
Yes, I can hear you.
Okay. I just want